Okay, so thank you everybody for coming to today's seminar. This is the ELSI seminar for Bridge to AI. And today we are extremely fortunate to have Dr. Tina Hernandez-Boussard, who's going to be talking with us about ethical issues associated with all aspects of artificial intelligence. Particularly, she's done a lot of work also in the notion of life cycles of AI. And so I'm very excited to have her here. I'm going to let Tina introduce herself because she's going to do a much better job than I would. And so I'm going to hand it over to her, and I'm going to hang out in the background. And then after she starts, we'll have a discussion after she finishes. Sorry.
Great. Hi, everyone. Thank you so much. Let's see, I'm going to share my screen. I'm going to get started here, and then let me just go, here we go. Oops, that's not what I wanted to do. 1 second. You would think that after doing this for so long, I would be very quick at being able to share my screen, but it always just takes me a moment. There we go. So let's see. Can you see that?
Yes.
Yeah, perfect. Great. So, thank you so much for this opportunity. I'm really grateful to be here and talk about some of the work we've been doing and how we navigate ELSI amid like the medical AI hype. Right. So I come to you wearing 2 hats. So as Brad mentioned, my name's Tina Hernandez-Boussard, and I wear 2 hats. I wear my hat as Associate Dean of Research. And I wear a hat of a professor of medicine. So as Associate Dean of Research, I lead the health informatics component of our CTSA grant, which really involves developing the infrastructure we need to support ethical AI across our School of Medicine, as well as our healthcare system. And in addition, it's ensuring we have the infrastructure for people to test and really do agile experimentation for AI in relation to ethical and the societal impact of AI. I'm also a professor of medicine, of biomedical data science, and of epidemiology and population health, where I lead a lab group of about 20 or so students across very diverse disciplines. And we focus on developing methodologies. We focus on evaluating methodologies, and we really focus on the application of AI into the healthcare system, and how we think about how we safely and equitably deploy AI across different settings. And so this is a really exciting job, because we know that AI is really revolutionizing how we think about medicine and healthcare delivery, but we also know there's a lot of challenges to consider, certainly in regards to the ethical, legal, and social implications of AI in health. So let's get started. Let me just see here. There we go. What's that? Am I on slide 2? Sorry. Let me just see here. There we go. So we know that AI has a growing role in health and healthcare, right? And it's really transforming the way we practice medicine at an unprecedented rate, right? From predictive analytics to diagnostic tools, AI is now deeply embedded across the continuum of care. Its applications span clinical decision support, hospital operational efficiencies, as well as clinical trial designs and optimizations. And this landscape has really been supported by advancements in technology, machine learning, natural language processing, large language models, of course. And these are all helping us make healthcare delivery smarter, faster, and even more precise. And today, it's not just about applying, whether we will apply AI to the healthcare system, but it's how are we doing this, right? Because it's already here. But we know that there are ethical concerns about AI in practice, right? We know that AI can make mistakes. And here's an example. This is an old example, but a lot of times AI has a hard time distinguishing between certain things that we as humans can see very clearly. So for example, the difference between guacamole and a parrot. And it all depends on what data was used to train the AI. And if the AI was not used on a diverse set of data to train it, it can make mistakes. We know AI is sexist and racist. Here's an example where an AI algorithm was fed a picture of Barack Obama, and the output was a white version of Barack Obama. And we know that AI learns biases in healthcare systems. And we've done some work looking at how these biases are learned in systems and carried out in practice. And this was some work we did, which was published in Health Affairs last year, talking about vaginal birth after cesarean section calculators and how they have learned and embedded these biases into the algorithm, and they're actually used in practice. But importantly, these mistakes lead to harms, right? And these harms are cumulative. And so we see these harms all across the spectrum of AI that's been deployed in health. We know during COVID, AI resource allocation algorithms discriminated against vulnerable groups. We know that AI in dermatology has underlying biases against darker skin tones. So these algorithms work really well at detecting melanoma on fair-skinned individuals. They're less accurate, significantly less accurate on patients with darker skin tones. And we also see this in regards to women, where ED triage tools fail to recognize heart attack symptoms in women because they were trained on historic clinical trial data, which we knew was predominantly males. And so these harms can be cumulative, as I mentioned, and they really have a societal impact, right? And they have detrimental effects for individuals, including misdiagnoses, for groups, including groups that are underrepresented populations. And then this makes harm to society as a whole. And in our Health Affairs article that we published last year, we really addressed the urgent need to tackle the structural racism in health that is being perpetuated by these AI algorithms. Right, we argued that the informatics community is so often captivated by the hype of AI and focused on improving model performance that often the ethical and the societal impacts of these algorithms is secondary to the performance of the model. And so I want to walk you through this and share some of the work we've been doing to think about this in a broader spectrum. So I like to use this framework to understand how we think about the ELSI impact of AI in health, right? And so when we look at this, we know that there's real world patterns of health inequality and discrimination. And these patterns in the healthcare system get captured in our data. And so this discriminatory data are used to train our algorithms. This generates algorithms that are biased by design, and these biases are perpetuated in the deployment of these algorithms. And then when these algorithms are used, we get application injustices, really a disregard and a deepening of digital divides, exasperating global health inequities and the rich-poor treatment gaps, and hazardous and discriminatory repurposing of these biased algorithms occurs again and again. So how do we think about ELSI and health AI? What do we do? What is our path forward? And this is where we've been really thinking a lot about how do we take a step back from the hype of AI and really think about how we can use it responsibly and equitably. So we've been addressing ELSI in regards to a holistic view of the AI lifecycle. This means that we don't look at models just in an individual stage of the AI lifecycle, but across the entire lifecycle. This means we start with data creation, the origination of the data used to train and evaluate the AI models. Where's my data coming from? For example, I often use our Stanford healthcare system data to train my models for AI. But it's important to ask, who has access to my Stanford healthcare system? Or more importantly, who doesn't have access? Who's missing from that system? And then when I generate my models using this data, who's not represented in that data set? Data acquisition is another piece of the AI lifecycle where we have to rely on IRB standards or the gathering or purchasing of data to train and evaluate the AI models. Now, according to my IRB standards, if I have a group that is too small, I'm not allowed to report on it individually. So for example, if I'm looking hypothetically at Native Americans with diabetes who have had a hip surgery and are taking opioids, which is a topic we look at often, I don't have enough Native Americans in that particular cohort to report on them individually. Therefore, I combine them with other groups. That means I can never really understand how my model is working in that population. I never know the accuracy in that population, and I can never go back and pull that population out. The next phase is model development and model evaluation. And this is where we've seen the most emphasis on AI in healthcare, where we're talking about accuracies of the model development. But what we don't see is all the different choices of the model formation and why a certain model was chosen over another model. In model evaluation, there is an overemphasis on model accuracy and less of an emphasis on the evaluating the equity of the model, the fairness of the model, the biases of the model. And then this moves forward to model deployment, where real world implementation and use of the AI model is generated. And here we have a big gap in standards, in use cases, in best practices. And so I think that by taking a step back and looking at the holistic view of the AI lifecycle, we have an opportunity to better understand the ethical and the fairness of these models we generate. And this is all based on transparency and trust, right? And so when we talk about the AI lifecycle, it's about being transparent about these different steps we take in building our AI models. And so last year, I chaired a workshop with the National Institutes of Health on transparency and trust. It was toward an ethical framework for AI in biomedical and behavioral research. And transparency is really at the forefront of ethical AI because transparency ensures stakeholders can make informed decisions about data and model reuse. And this fosters trust and fairness while ensuring that these models align with our regulatory frameworks. And this was a 3-day meeting we had at NIH. And the key recommendations from this meeting were that when we start developing these AI designs, they have to be developed, they have to be co-designed with communities. We have to establish standard documentations to really support the transparency of the models. This means things such as model cards, metadata registries, etc. So we know what's going into the model, how the model's been tested and trained on different populations, and the fairness of the model. Another recommendation was we need to expand interdisciplinary training programs so that the next generation of healthcare workers are aware of the challenges of AI in health, the opportunities for bias to be perpetuated using AI algorithms, and really an interdisciplinary training program that highlights these challenges with AI. And there was another recommendation to revisit IRB to address transparency, bias, and ethical considerations. This is a much larger recommendation, but I think it's something that we really need to think very carefully about. And we also identified important challenges in transparency and trust, such as data sovereignty and benefit sharing, right? So who owns the healthcare data? What happens when we generate synthetic data from our healthcare data? Who owns that data? And how do we think about the benefit sharing when we're using somebody's data to create these AI algorithms, yet they're not really seeing the benefit of the end product? And so this also leads us to how we think about moving from this theory for algorithmic fairness and bias to practice. And so we've done some work looking at the challenges for addressing fairness in AI models, prediction models, and its implications in healthcare. Now, I don't expect you to read all of these labels here, but I want to highlight just a few things. Because when we think about theory of bias and fairness in AI algorithms, we've done a lot of work looking at the data. So we have bias in EHR records, we have absence of gold truth standards. So we're really capturing this historical bias, right? And so when we identify that there's historical bias in our healthcare system, what does that mean for the implications when that an algorithm using that data is implemented in practice? We often have incomplete data. We're not capturing social determinants of health. So we often use proxy variables that get at not exactly what we want to measure, but something that brings us closer to improvement of models, right? So we might have a proxy variable. Race is a good example, where a lot of times we use race in algorithms, and there's no biological mechanism tying race to our outcome of interest, but it increases our accuracy of our algorithm, and it's a proxy variable. We have protected attributes that are also included in our algorithms, which brings us to some concepts known as race-based medicine. Again, going back to the proxy variable conversation. And then when we talk about models and evaluations, and there's an absence of qualitative criteria for fairness. So when is a model fair enough? When is it fair enough to deploy in practice? What are these guidelines and benchmarks we need to use to understand how fair a model needs to be used in practice? What are the trade-offs? The trade-offs meaning once we mitigate bias, we often take a hit in accuracy. So what's the right trade-off we want to drive for? These are questions that are unknown right now. They're challenges in our research community, and there's a lot of conversations about this. So I want to take this to some work that we've been doing and walk you through an example of how we're thinking about addressing a lot of these biases in some of our work we're doing. So we've been doing some work leveraging EHR data and large language models to understand reasons for why patients don't take statins. Now, statins are a class of medications used primarily to lower cholesterol in the blood, and they're known to help prevent cardiovascular disease, such as heart attacks and strokes. So a lot of benefits with taking statins, very few side effects. And so we wanted to understand why patients are not taking statins when they should be. So we developed sort of a framework for looking at tools to understand statin adherence. We first identified our cohort in our EHRs for patients who qualified for taking a statins based on clinical guidelines, but were not currently prescribed a statin. We leveraged and evaluated large language models to understand the text and the structured data in our models. And we did this to identify reasons for statin non-use. And what we found was that nearly 2 in 5 patients lacked guideline-directed statin prescriptions. And the reason for statin non-use included patient reasons, such as side effects, statin hesitancy, but also clinician reasons, such as guideline-discordant practice and clinical inertia. Okay, so we have our healthcare system at Stanford, and now we have a group of patients, a large group of patients, about 40% of patients who should be on statins, but were not on statins. And so we wanted to look at it from another point of view. So we then moved to Reddit. And so what we saw on Reddit there we go. Oh, I'm sorry about that. I'm skipping a slide. So we looked on Reddit to understand the discussions that patients had about, not patients, but individuals had about statins. And what we found was using a BERT model, which is a pre-trained language model on social media data, to understand both neutral and negative sentiments towards statins. It looked at positive, neutral, and negative, but we mainly found neutral and negative sentiments towards statins. We found that the reasons for people not being on statins were diverse. Some were statin adverse effects. statin hesitancy, clinical trial appraisals, pharmaceutical bias, industry bias, et cetera. So this really gave us a great view. So we had our view of our EHRs for why people weren't on statins. And then we had this view from Reddit for why people were hesitant to take statins. And so we wanted to understand, was this the same for all populations, or were these themes different across populations? So we next looked at the All of Us research cohort to look at racial and ethnic disparities in statin adherence. So what we did was we looked at social demographic data, healthcare utilization survey data, and the EHR data from the All of Us research cohort. And we found a cohort of about 20,000 statin users. And what we found was about 57% of them reported low adherence to statins. And so in digging across these different aspects of data within the All of Us research cohort, we found at the society level, there were structural drivers for access. So this included healthcare system inaccessibility and financial barriers. At the community level, we found social network barriers. So there were employment barriers where patients were listing employment barriers as reasons that they were not statin adherent. There was a relationship level, so provider-patient relationship interactions. And here we found both immigration status. Immigration status was related to hesitancy in patients seeking statin adherence. And then we also found individual levels, including patient anxiety. So what this enabled us to do was go through these different aspects of data to really understand statin adherence. And more importantly, in the All of Us research cohort, what we found was that these different reasons for statin adherence were different for each individual race and ethnicity. So for example, among our Hispanic patients, the number one reason for statin non-adherence was immigration status and patient anxiety. For a non-Hispanic white, the number one reason was employment barriers. And for our African-American individuals, it was patient anxiety and financial barriers. So each different population that we looked at in regards to racial and ethnic populations had a different reason for statin non-adherence. And I think this is really important because it highlights the unique social determinants of health influence statin adherence across these diverse populations. So that leads us to understand that fairness is not a one-size-fits-all, right? We can't look at how we think about fairness in AI and health with just focusing on this one-size-fits-all for all populations. So we need to really align our fairness metrics with intended use and ethical frameworks. And this brings us to this notion of equality versus equity, right? And what do we want our AI algorithms to do? Do we want it to really ensure that there's equality across the healthcare system? That means if everyone follows the clinical guidelines for statin adherence, anybody who qualifies for a statin should receive a statin prescription. Or is it more about equity? That there might be different needs across populations. And while everybody needs, everyone who qualifies according to the clinical guidelines for a statin prescription, there might be different pathways we need to take to ensure that people are adherent for their statin prescriptions. And looking at the individual needs of each patient is really important when we start talking about fairness and equality. So what's the path forward? You know, it's a big challenge because there's so much hype around AI in medicine, but I think there's several opportunities here. And one is to build bridges between clinicians, technologists, ethicists, and policymakers. This really needs to be a diverse conversation, not just about the AI technology and the hype, not just about the clinical need, but about the societal need and how we think about the ethicists and the policymakers and how they come together. We need to advocate for clear documentation and open communication about AI models and their limitations, right? Too often we have a model that we push forward based on accuracy alone without thinking about how they are biased across different populations. We need to design and implement AI systems that prioritize fairness and inclusion, especially for vulnerable populations. And this has not been the case in the past. We need to involve patients, communities, and healthcare providers in the development of these and evaluation of these tools to understand what is the societal impact of these tools. And we need to support policies and frameworks that ensure accountability, safety, and ethical standards. In the end of last year, we set out this framework for guiding principles for ethical AI in healthcare. And we have these different phases. Again, this is the AI healthcare system where we think about the problem formation. What is the problem we're trying to address? What is the data we use? What's the algorithm we're developed? So again, this AI lifecycle that I talked about previously. But we said, the guiding principles for ethical AI, we need to ensure that the questions we're asking really promote health and healthcare equity across the entire cycle. We need to ensure that healthcare algorithms and their use are transparent and explainable. Transparency, I think, is the key here for understanding where an algorithm can be ethically applied or appropriately applied to which populations. We need to really think about how we engage patients and community across all phases of the AI lifecycle. We've talked a lot about engaging patients and communities, but I think we need a lot more work in really authentically engaging them and including them in the work we do. We need to explicitly identify healthcare algorithmic fairness issues and trade-offs and set guidelines for what is fair enough to move forward in practice. And we need to ensure accountability for equity and fairness in outcomes from healthcare algorithms. It's not just about the top performing algorithm, it's about the outcomes the algorithms generate. And so when we think about algorithm to action and next steps, I think it's really important we integrate research with healthcare delivery and ELSI criteria. We need to do a better job at convening these multidisciplinary teams when we're designing, asking questions, not at the end phase, but really at the beginning of our process. We need to establish meaningful metrics that really highlight our desire to ensure the ELSI criteria and the fairness of these algorithms. We need to communicate our strategies with transparency. And importantly, it's about testing and reiterating on interventions to improve the quality and equity. Algorithms are not a static entity, and they need to continuously evolve and improve with the data and the healthcare system. And so with that, would like to just thank, I have a wonderful team of researchers, and I try and capture everyone, but I have just such an extraordinary team that I want to thank everyone. And so I will stop here, and I'm happy to take some questions. A lot of information I shared, and I'm looking forward to the discussion.
Yeah, that was great.
Thank you.
I have lots of questions, but since I'm gonna moderate, I'm gonna hold my questions for the time being, and I'll open it to the floor first.
Okay.
See if anybody jumps in. If not, I'm ready.
Well, it was a lot of things, and here we have a question.
Yeah, jump in. Go ahead.
Were you referring to me?
Oh yeah, sorry, you're the first in the queue.
I appreciate the talk. Everything was very relevant to what we do as well. Wanted to just reiterate what you said about the algorithms. The last point you made, all relevant. The algorithms are not static objects, and they need to be retrained. A lot of biases that we see as the result of the algorithm results we see comes from the data, while on itself it's not a static object, and it's being collected and improved to some extent. I just wanted to appreciate you mentioning that one more time and reiterate it. I think we need to talk about it more.
Yeah, and I think it's only by monitoring these algorithms after deployment in real time that we really get a clear view of the scope of the impact. And a lot of the impact of these algorithms we're not even aware of until we start seeing how they roll out into the populations. I find this similar to, post-market surveillance by the FDA, right? None of these drugs are put out on the market and then we walk away from them. And so I think there's a real opportunity to think about, do we need a registry to track the harms that happen from these AI algorithms? How do we keep track of these? How do we transparently, think about these? And yeah, these algorithms are not static, and the more we can reiterate and learn from them, the better they are.
That is true. One more point, if there's time for me to mention that, the more complex the algorithms become, I mean, back in the days, 5, 10 years ago, we used to split them into smaller, and we used to call them explainable XAI. Nowadays, they're so complex and they're getting more and more with the chatbots being more trained, personalized, et cetera. It's very hard to break them down and to make them explainable. So we're shifting to trustworthiness. That makes the problem of training data and the fact that we want to make them train the algorithms with the data, and the fact that we want to take off bias more challenging. And again, I wanted to just reemphasize what you said. It's getting more challenging. We need to act.
Right. And I'll say with the new GPTs and large language models, we don't even know what they're trained on anymore, right? So the new iterations of these models, they're not sharing what they're trained on. So we really need to think about, how do we think about the boundaries in which we use these models and sort of the guardrails? How do we better identify biases in these models so that we can prepare and understand the application of them? But it is a huge challenge.
Linda?
Hi, thank you. Great talk.
Thank you.
I'm just wondering about the regulatory agencies, the FDA, software as a medical device.
Yeah.
Because, it takes so much to get an algorithm approved. And I know they've updated their regulatory policy about updating algorithms, but is it good enough, and where do they stand? And perhaps you could share what the latest is, because in the past, you'd have a software for healthcare. I'm in ophthalmology, so we have a lot of retinal imaging, and they have all this software, and every software has to, and the first FDA approved AI system was for diabetic retinopathy detection, right?
Mhm.
And so it took a lot to get that specific algorithm approved. And I know the FDA has methods to allow the updating of the algorithm but can you share that? And do you think the regulatory agencies will be able to keep up with what we think are best practices? And
Right. Well, it is a moving target. And the challenge with the FDA regulation is historically, right, the FDA regulates things where we know the outcome. So you have specific inputs and the outcome that can be regulated. And with AI, it's continuously changing, as it should be, as we just discussed, it should be. And so that's the big challenge. And so what I've seen from the FDA over the past, and I know they just released something recently that I'm not up to speed on, but they are really pushing transparency. So they are pushing that we be more transparent in the training and the development of the algorithm. But one of the things I think is missing from the regulatory environment is the need for bias and equitable assessments. And so looking at algorithms across specific populations, across vulnerable populations, is not part of their regulatory framework as far as I know. So I think there's a big opportunity to think about that from the policy point of view. And now with the new administration, how that will move forward, will be interesting to see how that unfolds. But There is a lot of opportunity to set standards, I think, and they just don't exist right now. But I think even across the research community, as I mentioned, we don't have standards for what is fair and what is not fair. We don't even have a consensus on the definition of fairness. So when you think across a regulatory environment, I think it's a huge challenge in how we think about, these algorithmic biases, data representation. And I think we have a lot of work to do in that field.
Then let me ask a question. I'm going to push the fairness issue for a second.
Okay.
So even if there was a definition of fairness that everybody agreed upon, and we ended up in a situation in which an algorithm for diagnostics or for prognostics ended up being unfair by definition, would the implication of this be that it get pulled from the market? And if so, or would it be that it would be a call for a collection of better data, or would it be a call for saying that the algorithm needs to be made fair, even if that's at the detriment of having higher accuracy in its
Yeah, so that's a great question. And I think that my opinion is that no, it wouldn't be pulled from the market, but you could have a better understanding of which populations it can be applied to, right? If we know that a particular algorithm doesn't work on dark-skinned individuals, then we can make that information transparent. So then if a clinician or a healthcare provider is using that algorithm, they can make the decision whether this is the appropriate algorithm for the patient sitting in front of them, or not. It could also be a call for additional training data, additional information to improve that algorithm. But I do think it's more about understanding the applicability or the application of the algorithm to which populations. And this is really true when we think about community healthcare centers and these rural populations where often their demographics don't match a lot of the demographics from the training data that the algorithms were built on. How do they deploy those algorithms into their healthcare system? And it's about understanding the alignment of the training data with their population they're trying to apply these to. So I think that goes hand in hand, is that it's about transparency and knowing the right application. Is that, what do you think, Brad?
I don't know. I think it's an ethical dilemma that I don't think that I personally don't know the answer to, because on one side, I always look at this and say, would I be comfortable keeping a product on the market that I know works better for one group than another? And if I was to say that, well, buyer beware, you shouldn't use it with this particular group because it may not work very well for them. But then if you leave it out there, that means that you have a situation in which one group is going to continually benefit, at which point you may actually further a digital divide, so to speak, and that you're going to perpetuate and possibly even accentuate the disparity. And so it's a really strange scenario for me, because it's kind of like, and I've said this before, and people here may have heard me say this, it's kind of like saying you've got a drug that you want to bring to market, right? And the drug seems to work really well for some people, it doesn't work well for other people. So does that mean that you say, hey, you guys benefit, sorry, the rest of you don't get anything? I think it's a bit of it's a classical problem that I don't think is unique unto AI, but I think it's going to be accentuated by AI.
Yeah, absolutely. It's about the haves and the have-nots, right? And ideally it would be about collecting more data and really improving the accuracy of the algorithm across populations. But the problem, I think, is that, we've really harmed a lot of these populations. So they're less willing to share their data. They're less willing to contribute to the research. And so it's this catch-22 where we can't improve the algorithms without their data, but giving their data in the past has caused harm. So how do we overcome that barrier of trust and equity, right?
Yeah. Let's push on one issue that you brought up. So that I really appreciated how you talked about the notion of multidisciplinary investigations and
Yeah.
the need to do so. Do you have any examples of this that might have worked at Stanford that other people could learn from or use as they move forward, or is this an aspirational goal?
Yeah, and so I'll give you an example. And this is an example that I've seen firsthand, and that I have also have read about. There's been a couple people that have talked about this too, and that is, we have one of our issues with our healthcare system is no shows, right, in one of our clinics. And so this is a very interesting example where, the healthcare system says, okay, we want to identify an algorithm or develop an algorithm to identify patients who are no-shows, so that we can better, schedule, et cetera, et cetera. And in taking this back to our group, we talked about this, and, well, instead of predicting no-shows, can we not predict transportation issues? Can we not predict timing of appointments? Flipping that around. So it's not about predicting no-shows, but it's predicting barriers for access to care. And so this is an example where having that diverse conversation with what is it we're really trying to get at. So it's not just the conversation between the healthcare system and me, because there's a clear incentive for there.
Could you unpack that for a second? Could I back you up? So when you're thinking about the problem this way, are these variables that were considered as independent variables in the model, or are these variables that you only began to think about once you started to try to understand what the system was relying upon implicitly for prediction? Because this is a variation on a question I've asked Ziad Obermeyer on numerous occasions with their work, and it's like, the teachable moment has always been, you shouldn't rely upon proxy variables to the extent that we are, but then the question is, but do we even know what variables we should be looking for?
Right. And that's a great question. And so no, so right, our first model had very limited variables. And then when you start seeing the association or the groups who are most likely for no-shows, well, we know that, for example, Hispanic ethnicity has no associate or has no biological mechanism with a no-show for an appointment. So we have to unpack that, right? So what is it? What is it about this population? What are the variables in this population that we need to use to unpack that? So I think it goes, it goes back to thinking about the causal relationship between the variables, often proxy variables, which have no causal relationship with the outcome we're trying to predict, right? And so I think anytime we're using these proxy variables, we really need to think about, well, they're a proxy for what? Right? What is it what is it within this group? And oftentimes it's social determinants of health, which we don't collect regularly, or we haven't collected in the past. And so then that is a big challenge for us, creating these models that really get at the underlying reason for the no-show. So in our example, it was timing of the appointment. So if you're doing it in the afternoon, right, depending on the group, afternoon appointments where you have childcare or elder care, whatever it is, or was it, so timing was really important, and I'm forgetting the second variable right now, but we wouldn't know that unless we started unpacking that proxy variable, right?
Sorry, I know I've turned this
No,
more into a
please go.
dialogue than a
Yeah.
Q&A, but so is this a situation where the data that is being relied upon for the investigation, do you benefit? I know the answer to this. I'm leading the witness, but we have a lot of static data sets that are being created, right?
Yeah.
It's like we have an EHR data set or a reuse of an EHR data set, or we're doing analysis on found data sets that are just like they're being repurposed. The proxy variable problem kind of rears its ugly head in these situations because you're kind of dependent upon whatever was collected at that time. So so where does that put us, right? Like, does that mean that let's say you run the analysis, somebody runs an analysis and they've relied upon a proxy variable, they don't have the ability to go back to get this additional information. Is their research problematic in this regard? Like, should they not be doing the research because they're relying upon variables that are not causal? Or is it an argument that you should do it because it highlights that there's something here,
Right.
but we just need to get different data and possibly redo this analysis in the future, but it should be done in a different way than what you just did it?
And I think it's both things, right? I think we need to use those variables to understand and to characterize these differences. We need to know where these differences are and within which groups. But then it also goes back to, we need to, oftentimes these data we're using is data of convenience, right? It's convenience because they're conveniently collected. I have so many students come to me and say, oh, I want to study question X and I'm going to use our EHRs because that's the only data I have. And I'm like, but can you answer that question with these EHRs? And oftentimes you can't. But again, it goes back to data of convenience. So I think, yes, we need to use these proxy variables to characterize these disparities or these gaps we have. But I also think we need to move more towards moving away from this data of convenience and moving towards more comprehensive data sets. We try and use the All of Us research cohort a lot because it has a lot of these additional variables, but there's, it's not a perfect data set either, right? And it also has issues in data collection, et cetera. But understanding that there's an issue with a particular population allows us to dig into that population and try and think about, well, what are some of the other variables or what are some of the other features or interesting pieces about this population that could be related to my outcome of interest, right?
You and I are on the same page. There are other questions from the audience? Comments?
I actually have a comment. I wanted to reiterate what you all said.
Sure.
Every single items you brought up is a problem, and it's good that we're talking about it and thinking about it. No solution that comes to my mind, but talking about it is the first step.
Right. And I'll say, for example, at Stanford, we have a big emphasis to collect more social determinants of health for every patient who walks through the door, but we're getting a lot of pushback from our patients. And so they campaign this as, we ask because we care. And so we're asking about this information because we care. But again, it goes back to this trust and partnership with patients and populations that we need to really build upon and think about how we do a better job at capturing. And gosh, we're in the time of technology and AI and everything. There has to be better technologies to capture this data without being so burdensome on the patient. And so I hope that, there will be better ways to collect some of these social determinants of health rather than just a paper survey or a questionnaire that we give to our patients. So maybe that's coming.
And now you want me to push the hot button.
Yeah.
So play this forward because you brought up the big T. And I think the trust issue is one of the greatest challenges that we run into. So one of the things that we hear repeatedly, and we heard this in the All of Us program as well, which was, if you collect this information, can you tell me what it is that you're going to do with it?
Right.
Because if it's not directly relevant to my care at this time, or to the particular study that you're collecting information for even, then why am I going to provide this? And because it's a question of like, is this information that you now have that somebody may take and misuse or use or derive findings that are not why I would have provided this information in the first place.
Right.
And that's to me, that's a major barrier, because I don't know. I think we do know that there are differences stratified by demographics and trust with respect to the healthcare system, with respect to research in general. And that's a non-trivial issue to overcome.
Yeah.
And I'd love to hear you talk a little bit about this.
Yeah, and I think it has to be about shared benefit, right? So you're providing your data, what's your benefit? And what has happened in the past is there hasn't been a shared benefit across populations. I think it's really important when we collect this data from different individuals, they see the benefit. They see the benefit either personally or to their community or to their population, but we haven't done a good job at showing the benefit of these data we collect to their specific communities. And I think that's where there's a big opportunity, that if we can, and I mean, you can imagine that AI could be most helpful for some of these communities, where rural communities where they don't have access to care, so many things like that. And we just haven't done a good job at showing the benefit to these populations. And I think that if we could better promote, how they benefit from sharing their data, they would be more willing to share that data.
This is a tricky one. This is a really challenging one, because
Right.
research takes a long time, right? And we're reusing data sets. Think Jackson Hart study, Framingham, which all have their own biases, but we're reusing data sets that like we might not reap benefits from for 20, 30 years into the future.
Yeah.
Right. And
Yeah.
so there's this question about like, so what does it mean to reflect benefit back to a population that is not necessarily seeing direct benefit? Once again, a traditional research ethics question about, is the individual going to receive a benefit from participating in this, or is this something that's meant to be more for the benefit of the population that they're representative of, if it's clear what they're representative of? And so again, I think this is a situation which AI, which is going to like, or at least I'm thinking in terms of machine learning, is going to do massive scans across very large, wide, and deep data sets, that this whole notion of like, what is the definition of a group? What is the definition of like when do I come back to demonstrate benefit to you, and how do I show benefit to one particular group versus another group? And do I communicate in the same way? I leave this open as for a discussion point, because I think it's a really challenging problem.
But I think you said something really important. It's like, how do we define groups? And I think it's really important, I believe, that we move away from these groups that we've used in the past, Black versus white, Hispanic, and think more about these other groups, urban versus rural, education levels, financial levels, because those get more at the true differences in these social determinants of health that are more predictive, I think, of a lot of these outcomes and a lot of these things we're looking at, rather than the color of one's skin or some genetic ancestry that is not at all causally related with our output of interest. So how we think about groups and how we define groups, I think, needs to be revolutionized in order to account for this benefits and needs assessment, right?
Yep, totally agree. And it's
On the same page.
I will say, this is me laying my heart on my sleeve. There's going to be, even the proxy variables will continue to be important, because I do think that they will highlight disparity, and that even if there may be causal components or at least strongly correlative components that are more based on like social determinants, I don't think that we can rule out the fact that we do have, there are historical reasons for why we have disparities, and that those shouldn't necessarily sweep those under the rug.
Right. And also when we start having conversations about structural racism and the effects of racism on health, we need to keep, you know, this historical information in context, because it really speaks to a lot of this historical racism and the effects of racism, right? So
Great. Great. All right, we are towards the end. Are there any other questions or comments? We've got time for maybe one more. If not, I think we can say thank you very much, Tina. This was great on all levels. I think it gives everybody something to think about, especially as they're building data sets for this program. And I appreciate you taking the time to talk with everybody today.
absolutely. Well, thank you for the opportunity. You know, I love talking about this, and I think the more we talk about it, the better we get at disseminating this message. So I really appreciate this opportunity, and thank you, everyone. And please feel free to reach out if you have any additional questions, follow-up questions, etc.
Thank you.
All right, thank you so much. Have a
Thank
nice day. Bye-bye.